Okay, so I'm registering 1205. Welcome everyone to Chicago Asthma Consortium's Lunch and Learn series. We are very excited to have two wonderful speakers today to speak on the ACT versus AIRQ. So we will just get started here. Asher, if we could have the next slide. So briefly here, I'll say our little housekeeping things before I jump into our first speaker. As you see, here is our schedule. We will doing our our welcome and speaker intro right now. The first speaker will be Dr. Riva Kocha. She will present for approximately 10 minutes, then a 5-minute Q&A session. Please put all questions in the chat. We then will move on to Dr. Mackey with a short Q&A session, then we will close. So, kind of a quick and dirty, wonderful learning session today. Next slide. Networking. This is a networking and communications. Please use the chat, like I said, to say hello to people, to say your questions. Again, to put your questions in the chat. Please also, which is very important to us, share your thoughts about today's presentation afterwards. The evaluation link will be posted in the chat. Very simple, but it does go a long way in tweaking these series as we move into the future. If you're having any kind of technical difficulty, please, Asher is in the background, but he can help us and just email info@chicagoasthma.org for any assistance if you're having technical issues. Next slide. So who are we? Who is the Chicago Asthma Consortium? Our mission is to seek to improve quality of life for those with asthma through advocacy, education, and collaboration. Our purpose is to bring together medical, public health professionals, business leaders, government agencies, community-based organizations, and all individuals dedicated to improving the quality of life for those living with asthma. If you would like to help us make an impact, please go to our website, www.chicagoasthma.org, or you can speak to myself or Asher directly for more information. We are always looking for members. I haven't even introduced myself. My name is Felicia Fuller. I am the Health Promotions Director for the American Lung Association. I sit in the Chicago office, but responsible for all wonderful things lung health for Chicago, Greater Chicago, in the state of Illinois. I also am blessed to sit on a couple of national projects that we do regarding lung health as well. I am also, and I didn't say that on that slide, I am also on the executive committee of the Chicago Asthma Consortium. I am on the executive committee as the secretary. Matt Seamer is our wonderful president. He was not able to do this today because he's taking a well-deserved vacation. So without further ado, I want to introduce my dear friend, my colleague, Dr. Riva Kocha, Mimi, as I know her. Let me give a brief just synopsis of who she is and what brought her here. She is a public health nurse working for the American Lung Association as the manager of health promotion. There, she plays a critical role in coordination of mission activities, including lung health education, health promotion, and advocacy. Prior to working with us at the ALA, Dr. Riva Kocha worked as a NICU nurse advocating for families to have equitable access to quality care. It's critically important. She has also worked with the Chicago Public Schools to improve school management of chronic conditions for students, and holds her BS from Wheaton College in Illinois and her BSN from Loyola University, Chicago. And lastly, her doctorate from Rush University in advanced public health nursing. Dr. Riva Kocha is an Ecuadorian proud American, a lifelong resident of Chicago, passionate about environmental justice and community organizing, and of course is bilingual. Mimi, it's all yours.
Thank you. Thank you so much. Okay, I'm going to share my screen now. So thanks everyone. I know our time is kind of limited, so I'll give you the next few slides here a little bit quickly. And of course, as Dr. Fuller said, make sure that you can put any questions in the chat. I'm happy to talk more about them. Okay, so today we're talking about, asthma control evaluation. Specifically, we're addressing two different self-assessment tools. And so I'm going to start by talking about why should we even assess control, right? Like, why are we doing these things? Why are we here today to talk about this? So, Easy answer, because the guidelines tell us to do so, right? The NHLBI EPR3 guidelines tell us that we should be assessing the level of people's control so that we can appropriately adjust medication for an individual's patient's needs. Asthma, of course, is a lifelong chronic condition. You never outgrow it. It's with you forever, but with the proper management, whether it is a mixture of environmental control and trigger avoidance, as well as, of course, therapeutic management, we want to be able to control the asthma so that a patient can live with the best quality of life that they can with their chronic condition asthma. And the condition obviously can change over time. It can differ among people, age groups. And so we always need to be assessing whether or not our current treatment is actually working for that patient. Now, distinguishing between severity and control. Severity of a disease, so when you talk about intermittent asthma or any of the 3 persistent asthmas, mild, moderate, or severe, we talk about the intrinsic intensity of the disease process. So intrinsically, without any medication, a patient's asthma, how bad is it? What is the severity level, right? And based on that severity, let's say a patient has moderate persistent asthma, 12-year-old, then we would know, okay, we're going to initiate therapy for this disease at a level 3 or 4 out of our stepwise approach, which with the new 2020 guidelines would be recommended for a SMART therapy. I'm not going to get into that today, but if you want to learn more, you can always reach out to me. So SMART therapy would be then how we would do that. Initiate therapy based on severity. Nice, easy. It's not always that nice and easy, right? But then after that, we want to say, all right, we started you on this therapy, step 3 for this patient, 12-year-old, moderate persistent asthma. Now, what do we do? When they come back to see us, anytime they're with us, we want to make sure that their degree to which that asthma is impacting their lives is being actually we're actually controlling that. So the degree to which the manifestations of asthma are minimized by our interventions and our goals of therapy, that's what control is. So then we assess and monitor control to adjust therapy. Let's say this patient that we put on a step 3 medication was poorly controlled. We would go up to step 4. Let's say this patient was doing really well. For 3 consecutive months, they had barely used their rescue inhaler. They were doing really well. They weren't having the symptoms that they were before. They're able to participate in sports, this 12-year-old. Then we could actually maybe go down a step, right? So we can adjust therapy based on control. And then severity is what helps us to initiate therapy. So very important difference there. So today we're talking about control. There are several validated patient self-assessment options for patients to assess for us to use with patients to assess their level of control. ACT, or the Asthma Control Test by GSK, is one of several. AIRQ score, which Dr. Mecki is going to be talking about from AstraZeneca, is also one of these options. We also have ATAC, the ACQ track. We have different options available for us, and depending on our EMR, the patient's age group, the availability of the language options for those tests, whatever, we might choose one over the other. Asthma control test, today I'm talking about it because it is one of those, and maybe one of the more frequently used ones. It is for patients. There are 2 different types, actually. So there's the asthma control test for those from 4 to 11. So that's the ACT for children, or childhood ACT. And then we have one for those who are 12 and over. So just our ACT. Because they're validated, what I mean by validated is that there has been published literature saying, yes, this is actually a valid tool, evidence-based tool that can actually help us to know whether or not this patient is well or not well controlled. ACT for those who, for all these patients, has a 4-week recall. So it'll ask us in the last 4 weeks, what are your, how often have you had symptoms or used your rescue medication, limited your activity. There's also, for the childhood questionnaire, there are 7 questions, because there's also a couple of questions based on risk. So, maybe have they gone to the ER or something like that, or been on an oral corticosteroid. So we talk about daytime, nighttime symptoms, our use of ASABA or rescue medication, and any limitations. So 5 questions for the 12 and over and 7 for the childhood ACT. One good thing about ACT is that it is available in multiple languages. And so you can have people from different, who have different language, primary languages utilize this. Also, it is better at predicting the level of asthma control than FEV1 alone, right? So if we were to do a spirometry test, which is for 5 and over, we can look at FEV1 and see how well controlled the patient is or symptoms, but this overall helps us to capture the big overall picture. And so using them concurrently actually can be really helpful. In terms of scoring, the asthma control test is a questionnaire that is out of 25 possible points. The bigger the number, the better it is. So 20 and over is going to be our well-controlled. And then those between 15 and 19, that means that this patient's asthma is not well-controlled. Anyone under 15, unfortunately, that they would be very poorly controlled. That's what that would be indicating. So again, here it is, 15 or lower, very poor controlled, 19, so 15 and 19 now well controlled. And what this means is that there is a 70 to 84% chance that this patient is not under control. And then 20 or more is well controlled. So 3 out of those 4 patients are under control, because 1 out of 4 can be a false, 1 out of 4 can be false negative, but the higher the better. We want 20 or more. Now, putting it all together. So the classification of asthma control, right? We talk about our guidelines, right? Everything we want to do, at least with the lung association here, is evidence and guidelines based. So we can have well-controlled, not well-controlled, or very poorly controlled. And what we do based on those responses is going to be, or what we do is going to be based on which one of these categories the patient falls under. ACT is at the very top row, and I included other ones there too. So ACT, again, 20 or over, well-controlled, we're good. What that means here at the very bottom, recommended action, is to maintain the patient on that medication. Follow up, a couple months, and then we can consider stepping them down if they are well controlled for those 3 months, right? Because with asthma, and here's a little quick aside, oftentimes I think us in primary care can sometimes think of, we want to be a little bit careful with medication. Unfortunately, primary care providers tend to underdiagnose or underrate the severity of people's asthma, and then we start them sometimes low. What we want to be doing is giving them enough medication to control their asthma, so they can actually have, better quality of life. And then we could always peel back. That's what the stepwise approach is beautiful for. It goes up and down depending on patient's control. So let's say we did start this patient, this 12-year-old moderate, asthmatic, who has a person with asthma, who has maybe a lot of symptoms. We started her, let's say, at level 4. She's well controlled. Her ACT tells us she's a 24 score, she's been great for 3 months. Maybe we want to go to step 3. So that's what we would do if they were, again, well controlled for at least 3 months. Otherwise, just well controlled, we maintain, we follow up. Now well controlled, that 16 to 19 score for ACT, that's when a person, we would consider stepping them up a step. So we would actually say, okay, this patient, this is not currently working. Let me take it back. First, are they filling their prescription? Are they actually compliant with their medication? Secondly, are they utilizing it correctly, right? If it's, let's say, a medication that's an MDI, do they use a spacer with it? If it's a DPI, do they know how to actually open up the capsules and have enough pressure to actually take the medication into their lungs? Did they get a new pet? You have a rug in the room. Do they have pillows or blankets or stuffed animals that they sleep with? And maybe that's a trigger, maybe dust mites are a trigger for them. Obviously, we want to look at that too. Compliance, ability to take their medication properly, and environmental control. Let's say those are all great. Then let's think about stepping them up a step, right? So we would step them up, and then we would reevaluate. We want to keep a closer eye on that person and reevaluate in 2 to 6 weeks. So then that's what we would do. Now, if a patient is very poorly controlled, this patient is in need of intervention, right? We need to do all of the above. Make sure that we are trigger avoidance. If you live in Illinois, we here at the Lung Association can help those patients with a virtual home assessment to make sure that they have what they need to mitigate any environmental triggers. You can always talk to Dr. Fuller about that. She helps to run that program, and it's free for them. So consider, referring them out to make sure that they have good control of their triggers in the home and schools and stuff, but also consider then stepping them up, maybe 1 or even 2 steps, because again, we really need to get them under control. And we want to really evaluate that patient within weeks. Is this working for you? Come back in 2 weeks. Also, we would maybe consider short course oral steroids. And we do know, as the guidelines tell us, unfortunately, if we are starting them on a short course, if we start them on oral steroids, kind of means that something in their treatment plan has failed. So we really want to avoid getting to this, right? So again, we always assess control so we can keep them in that well-controlled part and not let them get to the very poorly controlled. However, things happen sometimes with patients, they're not compliant, something happens in their environment. So this is what we would do. I did also include other scores there. As you can see, I'll let Dr. Mackey though talk about the AIRQ score and kind of all this put together. And then before I do that, I want to talk a little bit about strategies for using these tools in your practices. So first, think through, how are patients going to be identified who need this? Are we doing this for all patients, or are we doing them when they come in for an acute asthma exacerbation? I would argue we do it all the time. Any person with asthma, we want to know, is it working? If it was working 3 months ago, it doesn't mean it's working now. And if it wasn't working 3 months ago, we hope it's working now. Think through who's going to give it out. Is it going to be someone during the rooming process, an MA, a nurse, CNA? Is it going to be the provider? And then who's going to score it, right? Recently here in Montana, where I am today, I saw a clinic that had a whiteboard it had a laminated sheet with a dry erase marker, and then they would give it to patients, have them circle the numbers. They would then score it and then erase it, and then the next patient can utilize it. So the patient does it, it's a paper form. So if you think about paper, how do you make sure that it's in your EMR so you can see the scores over time, right? What was it like 3 months ago and 6 months ago? Have we continued to be well controlled? Have there been any ups and downs? And so that if they come and see a different provider, the different provider can easily look at it. Can it be part of your flow sheets? Is it a scanned document and put into your note? Think through these things. And then not just that, but how do we talk to the patients about that? How do we let them know? You know, sometimes the definition for a patient of control is very different than our provider definition of control. They can say, yes, I'm really well controlled. I take my albuterol every day. We know if they're taking a rescue medication every day, that means automatically they're not well controlled. So we can talk to them and say, these are your numbers, these are your scores. Think about using it with spirometry, and then also think about other self-assessment processes in your clinic, your hospital, your service, your school that utilizes patient self-assessment tools. And can we model this after maybe like a depression screening or something with another chronic condition if you're trying to integrate this and don't have it yet? Is it part of your EMR and you just need to turn it on? So think through these things. And then hopefully this has been a helpful tool for you. One of, again, several validated tools, maybe one of the more frequently utilized ones. And I do find that a lot of healthcare systems and EMRs do have this in their system. So that is all for me. I'm going to stop sharing my slides. I hope you learned something new today, and then I'll hand it back over to Dr. Fuller. Thanks, everyone.
Am I on? Oh, thank you, Dr. Ribacocha. That was nice. I don't see any questions per se in the chat. But you know me, I'm always going to have a baby question. I just love that second to last slide. Many times it's a little foggy in my mind as a public health non-clinician person. But I guess my question was, and what kind of struck me was those that are under 15 that are very uncontrolled, and getting them in the office, and then you're asking them to come back 2 weeks later. That even the first group that was well controlled 3 months later, and that in public health is a somewhat serious issue. What does it do? Of course, if you're not controlled for long periods of time, the ultimate is unfortunately could be death. But what is the long-term? Is there any long-term issues with not being controlled, or going to the doctor, getting the meds, and then unfortunately not coming back to secure and really figure out where that patient is?
Yeah, so uncontrolled asthma unfortunately happens more often than not, unfortunately, because patients, for whatever reason, right, they're not taking medication, maybe it's an insurance issue, and poorly controlled asthma over time, you know, there can be lung remodeling. Unfortunately, when we talk about COPD, we talk about sometimes COPD comes with patients who have that asthma that's been uncontrolled for years and years and years, and they hit 40, 45, 50. And they are seeing not just an obstructive disease, but also now a restrictive disease and kind of some airway remodeling. And so we really want to help them to know, like, this, we want to have it controlled so that it doesn't progress, right? We can actually keep you from that, having those symptoms all the time, and from needing an albuterol every day, which the only way to really control those patients who have persistent asthma is a daily controller, right? And sometimes that's the hardest battle that people have in primary care, is to give patients the medication, to have them come back.
Mhm.
Also, right, there's not just always medical emergencies, but there's also sometimes social emergencies, like taking time off work, taking time off school, finding a caregiver, finding transportation. So think also holistically in terms of social determinants of health,
Mhm.
health equity, and accessibility for those patients to utilize your services. And what can you do? Maybe it's a virtual assessment in 2 weeks. Maybe it's a nurse phone call.
Mm,
Maybe
mhm.
they don't have to come in person, but you still want to ask them those same questions to see if their
Absolutely.
control ACT level score has changed. Think
Mhm.
kind of outside the box, especially for patients who might have other barriers from bringing them back into the clinic in a couple of weeks. So that's kind of what I would say is we really, they suffer a danger of having exacerbations, having ED visits,
Mhm.
unfortunately also getting hospitalized and even dying if they
Yes.
have uncontrolled asthma. People should not be dying of asthma, but they do. They do every year. And so if we can assess their control and stay on top of it, hopefully we can help to eliminate some of those unnecessary deaths and injuries.
Wonderful. That is very well said, Mimi. That's extremely well said. Thank you very, very, very much. Dr. Rivacocha also mentioned that the Lung Association does do home assessments for those in the state of Illinois, those who need adults and children who need those extra services of virtual home assessments and what is needed in the home. We give free products away, green cleaning products, beds, whatever's needed to assist the patients in mitigating their homes and reducing their asthma symptoms and lowering these ACT scores. So if anybody does want to get in touch with me about that, please do, and we can set you up for these wonderfully free taxpayer paid services. So without ado, we will move on to our next speaker. Dr. Mackey, Alex Mackey, originally hails us from Toronto, Ontario, Canada, and attended, let me see, my little sheet here is cutting off your university. Attended McMaster University for his undergraduate studies. He obtained his PhD in pharmacology from our wonderful Loyola, where Mimi went as well, in Chicago, and completed his doctoral training at Northwestern prior to becoming a research faculty member at the same institution. His career has transitioned to industry in 2016 as a medical science liaison and has been a senior respiratory MSL with AstraZeneca for the past 5 years, supporting therapies and clinical trial programs within the asthma and COPD disease states. We would love to welcome Dr. Mackey to guide us in our second half of our What You Learned series today. Dr. Mackey.
Thank you very much, Dr. Fulla, and thank you, Mimi, for giving a very nice overview of the ACT. I'm just going to share my slides here really quick, and I think it's nice to see, Mimi, that the awareness of the AIRQ as a new questionnaire is out there. You're clearly aware of it, and I'm sure other providers are as well. So I figured this would be a really nice venue to kind of highlight maybe some of the things that it does a little differently, and some of the strengths that this test has. So I will say that I am one of 2 MSLs in Illinois. You may be more familiar with my partner, Andrea Fuller, and if you have any questions related to this material and you go to her for that kind of stuff, please consult her. Otherwise, I have my email there, and I'm happy to follow up with you if you do have any other questions about the AIRQ at the end of this presentation. So the discussion today is really going to center around asthma care tools, and it really centers on a larger program called Precision that AstraZeneca has been involved with for the last 5 years. So the objectives today are really, one, to understand the origins of the Precision program, just to give you a better context of why and what actually happened from the Precision program. We'll spend a very brief amount of time heightening awareness on, what Mimi alluded to, the overestimation of asthma control and what that really means for a patient, and and the costs involved from a systemic standpoint. And thirdly, we'll learn how the AIRQ and the accompanying evidence-based educational materials can help identify and help act on uncontrolled asthma. So without further ado, let's jump into this here. The Precision program is an unbranded initiative. So yes, I work for AstraZeneca, but this is a completely unbranded initiative. All the data that's been collected for the AIRQ produces products that are free for use by providers. And as you'll see with the AIRQ, that is the same. we're really dedicated to improving the identification and management of patients with uncontrolled asthma. And the rationale for trying to come up with a program around that is based on a network of greater than 200 advisors across the United States. And these are people that you would consider to be thought leaders geographically or internationally. They include pulmonologists, allergists, primary care physicians, as well as everyone within the allied health provider network that has their hands on asthma patients. So please be aware that, you know, this is not just us. This is really coming from people just like yourselves who felt that another tool and a more accurate tool was needed to really help asthma patients. And I'd be remiss if I didn't go into the burden of asthma in the United States. I think everyone on this call is aware of it, but it's worth reiterating is that 25 million people in the United States have asthma, and that represents about a 2.5-fold increase since 1990. We know that 60% of adults with asthma have uncontrolled asthma. So despite the severity, whether it's mild to severe uncontrolled, patients can be uncontrolled or controlled within those domains. We know that 44% of children with asthma are uncontrolled, and that's unfortunate as well. And lastly, about 65% of people greater than 12 years of old with persistent asthma, unfortunately, have to use OCS, whether that be a daily utilization or whether that be a burst pattern to get exacerbations under control. And what's really profound about that is that if we look at the bottom half of this slide, you can see that the advancements in asthma treatment have been pretty profound over the last, 8 or 9 years. We started out with ICS LABA, Xolair came on the market just before 2004. LAMAs alone, the IL-5 receptor and the receptor antagonist are out there. We've got IL-4, IL-13 inhibitors, the triple inhaler in asthma, as well now the newest kid on the block is anti-TSLP biologics. So despite all these therapies, we know that there's a lot of other factors that mean that asthma control and uncontrol really persists. So perhaps better strategies are needed. So how do we address the comprehensive burden of uncontrolled asthma? We know that asthma control really consists of 2 domains, and these are represented by the symptom impairment and exacerbation risk domains. As asthma control worsens, the chance of an asthma attack increases, and that's why it's so relevant to try and understand where a patient sits in the control spectrum at any given time point. We know that many asthma control questionnaires are recommended by the expert guidelines, as Mimi nicely went through. However, they really only address the impairment domain, with the exception of maybe the pediatric version of the ACT. Both the ATAC, ACQ, and adult ACT don't really get at the risk component, and risk meaning oral steroid burden, hospitalization, unscheduled visits to healthcare. And so the Precision program was really initiated to develop innovative and validated tools to really improve the identification of uncontrolled asthma in the population as a whole. So with that, let's just get right into the test itself. I know a lot of people probably have not laid eyes on it, but it's a very simple and easy to use assessment. The Asthma Impairment and Risk Questionnaire, known as the AIRQ, assesses both impairment and risk. If we look on the left-hand side here, you can see it's a very simple test. There's 10 questions. The first 7 of them refer to impairment. So they're talking about how do symptoms impact a patient's day-to-day life, sleeping, activity, so on and so forth. And it's simply a yes or no. So all we're doing, we're not asking patients to grade between a scale. We're saying, does this impact you or doesn't it? If it does, check yes. If we move down to the last 3 questions here, you can see these really relate to the risk domain. So number 8, have your symptoms caused you to use steroids in any capacity, over the last 12 months? Yes or no? Have you gone to an emergency room? Have you stayed at the hospital overnight? Simply just add up all the yeses, you get a composite score, and then you take that number and you relate it towards the scale at the bottom left. And this really relates to, what does my AIRQ score mean? Well, if you're in the green level, meaning you haven't answered yes to many of these questions, then you're considered to be well controlled. I will state that, as Mimi mentioned for the ACT, this is highly validated. There are, at this point in time, 5 independent publications in the domain that have shown specificity and selectivity of these tests to compare between the different ranges of control, and it has been validated against the ACT directly as well. So we know that it's a predictive tool, we know that it's helpful, and we know that it's validated by our research scholars. Secondly, if we move into the yellow range, that's considered to be not well controlled. And lastly, anything 5 and above would be considered to be very poorly controlled. I do want to point out that these are equally weighted questions. They're yes or no. And again, it composes 7 impairment questions and 3 risk items. You can see that from our validation structure, 90% sensitive to identify between these groups and 96% specific. So, you know, the false positive and false negative rates are extremely low. I will ask if you want, there is a QR code here. This will take you to the asthmaresourcecenter.com. That has access to the AIRQ and any questions you may have about it. It also has a number of different resources if you have an interest in incorporating this into your EMR or your practice as a whole. So I urge you to scan that code and we can move forward. I'm also fully willing to help you if you'd like to just talk to me directly. One of the other elements of the AIRQ that is maybe a differentiator compared to the other questionnaires is that it's actually predictive, and the data bears this out. So we know that, you know, uncontrolled asthma leads potentially down the road to an exacerbation or worse conditions. What we were able to determine in our data set is that patients that are well controlled have a much lower risk of an exacerbation compared to those that are considered not well controlled or very poorly controlled. To the order of anyone in the yellow range has about a 2-fold increase of having an exacerbation in the next 12 months. And if you're very poorly controlled, it's between 4 and 5-fold higher risk of having an exacerbation in the next 12 months. So it doesn't tell you what to do, but it does give you a sense that that patient, we need to intervene somehow. We need to step up therapy. We need to consider, you know, their living conditions or any other factors that, you know, we really need to get under control because they're at risk for an exacerbation. And as Mimi and Dr. Fuller have mentioned nicely, unfortunately, this can lead to very dire outcomes for patients. We also want to point out that, you know, from a standpoint of overestimation of control, it's rather persistent. You know, if we look on the far left here, we can see that 32% of patients who assess themselves as completely well controlled actually had greater than or equal to 1 exacerbation in the next 12 months. Those patients that are considered well controlled by physicians have a 30% risk of having an exacerbation in the next 12 months. And those as predicted by as controlled by the ACT, 29% of them have a risk of having an exacerbation in the next 12 months. And if we compare that to the AIRQ, which incorporates both risk and impairment questions, we can see that only 15% of those patients had an exacerbation in the next 12 months. So it's a little tighter, and you know, it's just a sense of the types of questions we're asking to get a better sense of control over time. That and the fact that it is predictive of what might happen to them in the future. So I don't think anything is better than anything. I think if we use it appropriately in the correct population, as Mimi mentioned, you know, everything can be a composite tool that we can use together to try and make sure that patients are more controlled. Why do we want to do this? Why do we want to know that patients are well controlled? Well, one, we know we want to try and prevent exacerbations from occurring, but we also want to prevent the negative side effects that oral steroids or systemic corticosteroids can have on patients over a long period of time. I won't get into the nitty-gritty details of this given the time, but I do want to point out that, you know, oral steroids are a go-to for patients. They are the gold standard for trying to get an exacerbation under control. And for patients that exacerbate frequently, this can become a pretty profound problem of accumulation of dose. You can see those that have 500 milligrams to less than 1,000 milligrams of cumulative lifetime dose have about a 20-fold increased risk of type 2 diabetes and depression. Now, if we expand that maybe out to 3 or 4 exacerbations and 3 or 4 bursts of oral steroids, you can see a plethora of other potential very harmful side effects start to emerge. So it really behooves us to try and make sure that we're using all the tools we possibly can to really get patients under control. In terms of licensing the AIRQ, it's completely free. You know, we're not charging anything for this. We'd really like you to use it if you feel it's a useful tool for you. It's available in a number of different languages, as you can see here. And there are supporting documents that, you know, can be found on the the asthmaresourcecenter.com website that can help you incorporate this into your EMR. Using, you know, a smart phrase is a lot of how some institutions have been able to do that. But there's a plethora of data. There's hundreds of abstracts, 5 formal publications that support its utilization in asthma across the spectrums of severity. So I urge you to reach out if you think this would be a useful tool for you. So just in conclusion here, we talked about the burden of uncontrolled asthma. We talked about some of the assessment tools that might underestimate exacerbation risk and the importance of maybe asking those risk questions to get a better sense of control. And I shared with you a little bit about how the AIRQ is predictive in nature and perhaps maybe a little more stringent as compared to existing questionnaires in really defining control of your patients. And lastly, if, you know, I'll just leave this up if there are any other questions, but, you know, azmedical.com also is a link to, you know, AIRQ related resources. You know, there are physician portals to get in here and you can find out anything that might be respiratory related, whether it be asthma or COPD that AstraZeneca is involved in. So I urge you to reach out to that if you have any other questions. So with that, you know, I appreciate your time and happy to kind of follow up on any specific questions related to the AIRQ.
Okay, I don't see any questions in the chat, at least not right now. Oh, can we get a copy of these slides? I think that's something we do, Asher, correct? Send out these because all the slides are very good.
I can definitely tell you that the Asthma Resource Center has all of the materials that I've presented and they can be accessed there. I can't formally provide you this deck,
Okay.
but you know, the resources are available on that website for download personally.
I don't know, if Dr. Weaver coach is still available.
Yes, I am.
Are
And
we okay with sharing your slides?
yes, yes,
Okay.
we can share a
Wonderful,
PDF version
yes.
of it.
Okay, and Asher can distribute those. Okay, any other questions? I guess quickly, again, as a public health person, what I noticed is I do like the form. What did it go through a readability, you know, some kind of readability process to make sure that it was at a 4th grade level? That was just things like that poke out to me.
Yeah, absolutely. So right now that tool is only validated for patients that are 12 and up. So we are working on a
Okay.
pediatric version of it, but you're absolutely right. Those questions are a little, you know, it wouldn't be appropriate for a 4 or 5-year-old to be reading that and trying to address those questions. They would need assistance. But again, it's only currently validated for 12 and up, but we
Okay.
are working on a version that would be validated for a younger age group.
Okay, that's very important to know.
Yep.
And even for those who have trouble with reading that are older, or it seemed like some wordy words in it. That would be a little bit of an issue. Other than that, I thought it was a very good tool. So
Yeah, and I think this is done in conjunction. We would never just send a patient off with this form and ask them to fill it out. I think it really needs to be done consistently with a healthcare provider of some sort within the spectrum of asthma, you know, care. And additionally, I'll say that, you know, there are 2 versions of the test. So there would be the initial test that would look back 12 months, and then a follow-up assessment that would look back 6 months. I think one of the things that's really nice about this is that for those patients that you might not be seeing as frequently as you would like, as Dr. Fuller, you mentioned after Mimi's presentation, this is still going to give you a look back over 12 months and give you a very quick snapshot of where that patient sits in control when they are in your office at that time point. So.
So yes, a professional would need to definitely, in ACT, a professional does that one for the most part.
Yes.
The ACT, the words are just very simple. That's part of it. But yes, I love it, and I'm going to be. That was the first time I heard a very good and in-depth conversation about it. So it looks like Asher is saying we can provide links to where you discuss Dr. Mackey
Yes.
and Dr. Reebok Coach's stuff, slides will be available. So yes, our 30-minute, but we knew today would go a little bit longer. Lunch and Learn, quick and dirty. I thought it was very insightful, very engaging. We did record this, so if you have any friends, others that would love to hear this information, the recording will come out as well. We knew it would go into 40-45 minutes, wonderful information. Again, thank you for attending today. Please look us up at chicagoasthma.org. We are always looking for memberships. We are also have committee that does wonderful things as well. So I think, Asher, that our next, this is July, I want to say our next Lunch and Learn is September maybe, and we don't have a date because these are really a lot of times dependent on our speakers' availability as well. So they're just not, we can't say they're going to be every second Wednesday of the month because, or the every other month, because again, we are working with wonderfully qualified professional people that are very busy like all of us are, and we are dependent on their schedule. So we hope to see you at our next one. We will be marketing and publicizing it. So without any further ado, have a wonderful hump day, Wednesday, and enjoy your summer wherever you are in this country. Take care.
Thank you.
Thank you.
Bye, everyone.